Now, looking at acute appendicitis, it is the most common surgical abdominal emergency in North America. About 30% of the time, the patient's symptoms and signs and the lab findings are atypical. Now, a lot of times, as already mentioned, when patients or females come in with right lower quadrant pain, more often we're going to find something like this, a hemorrhagic ovarian cyst that is causing their pain rather than appendicitis. It'd be wonderful if all cases of appendicitis look like this. You can see this is 1 centimeter underneath the skin. Here we can see all this edema and swelling of the cecum. Here's the appendix coming off. We have an appendicolith here. You can see distension of the lumen. There's some fluid within here. We can see that there's abscess within that. But it would be wonderful if all cases of appendicitis were this easy to identify. You can see this is the same case, a grayscale image of it. Here's the appendicolith and distension of the lumen. You can also use color Doppler and look at the inflammatory hyperemia. Now, the key to diagnosing appendicitis is what we like to call thyroid in the belly. And if you look at this area surrounding the appendix, this is just edema of the normal fat that surrounds the appendix. If we look at CT findings, what they're looking for is that stranding of the fat. And we can see the same thing on ultrasound. So when I actually look for cases of appendicitis, what I'm looking for is that echogenic fat, or also what we call the thyroid in the belly. You can see hyperemia within the appendix. It's not something we look for all the time, but if you do see increased blood flow, typically it is going to be low velocity flow. You may see some pulsatile venous flow within it, but that is something that we will see with the inflammatory appendix. Here you can see scanning the cecum in a long axis view. You can just see distension of the lumen through here. And look at all the edema that we can see within that cecal tip. Short axis view of the cecum, you can also see all the edema that we see from the inflammation of appendicitis. This is a 10-year-old male patient that came in with right lower quadrant pain. And in scanning the right lower quadrant, we could see that he had enlarged lymph nodes. Now, you can get mesenteric lymphadenitis that we see quite frequently in these children that come in with right lower quadrant pain. But also appendicitis can cause the lymph nodes to enlarge. So what's very key on these patients is to scan and try and find the appendix. And on this young man, we're able to find that he did have a normal appendix, and the lymph nodes, he actually had was diagnosed was mesenteric lymphadenitis. So that's just a viral infection. The patient will get well on their own. No surgery is needed. So key to ultrasound is locating the normal appendix and proving that it's not appendicitis, causing the lymph nodes to enlarge. This is a patient that, as we call, has on their winter coat. You can see even before we get to the area of the inflammation, we're already at about 4 centimeters, 3 to 4 centimeters in depth. Sort of a key to remember, when you're using your high-frequency linear array transducer for any type of imaging, when you're trying to look at a structure deeper than 3 centimeters in depth, you're starting to push that transducer too far. So when I started scanning this patient with a high-frequency linear array, I noticed that I just saw this fuzziness deep in the image, and then, as I mentioned earlier, what I like to do when I switch to a lower frequency transducer is to actually go to a curved array because you get a wider field of view. You can see there's just this big fluid collection and a lot of edema going on. There's a lot of different inflammatory processes that can cause this thyroid in the belly type of appearance. But in scanning around, what we're able to do is find what appeared to be a normal appendix. And this is appendix that has perforated and compressed. And then we have this big phlegmon, or this fluid collection, deep in the right lower quadrant. So what will happen is once the appendix ruptures and all of the fluid or the inflammation is outside of it, it will decompress and a lot of times return back to what appears almost to be a normal size. Appendicitis can also resolve. This is a patient that the appendix was enlarged. We followed them up. You can actually see that there's distension of the lumen, some pus in here. And this appendix only measures 6 millimeters. We followed her up and it returned back to a normal size. So we have seen cases of appendicitis that resolved as long as they do not have an appendicolith obstructing the appendix. You can see there was still some hyperemia within this appendix on color Doppler in the short axis view. This retrocecal case of appendicitis, here you can see the cecum, distension of that, but look behind the cecum. This was the key to diagnosing this case of retrocecal appendix, is all this thyroid in the belly. And if you look right in the middle of this echogenic fat, this is where we see the retrocecal appendicitis. There's also increased blood flow when we look on power Doppler and pulse Doppler, looking at this case of retrocecal appendicitis. So sonographic diagnosis of appendicitis in patients with right lower quadrant pain, what we look for is a non-compressible appendix. I put here 7 millimeters or greater. And you're saying, well, wait, Cindy, earlier you said the normal appendix was 6 millimeters. The key that I want to make is, once again, as I already mentioned, we're all as unique on the inside as we are the outside. And I don't like to use just a certain number. You want to put the whole clinical picture together. Typically, the normal appendix only is going to measure about 3 to 4 millimeters in size, but I've seen normal appendix that measures up to about 8 millimeters. Patient was non-tender over the appendix. It measured 8 millimeters in size. There was no hyperemia within it. So I want to just sort of remind everybody that you don't want to always stick to a certain measurement, that there is variation within that. If you see the presence of an appendicolith that is abnormal, edema of the mesoappendix and fat surrounding it is, I think, the key to the diagnosing of acute appendicitis. And you can use color Doppler and look for the presence of hyperemia or increased blood flow. So looking at this long axis and short axis view of a case of appendicitis, and once again, I want you to notice the thyroid in the belly or the edema surrounding this. This is the mesoappendix coming off here. Now the mesoappendix is just sort of a little layer that attaches the appendix to the cecum, so that we can see inflammation within that also, but that is the mesoappendix attaching it. This is a long axis view of a case that we did several years ago. In fact, this is from the good old days of annular array technology, but also you can see that the case of appendicitis is about 3 to 4 centimeters in depth. Here you can see edema of the cecum. Here's an appendicolith, the appendix diving deep. When we image deep into the tip of the appendix, you can see that there's a second appendicolith here, but also notice all this edema of the fat that we can see surrounding the appendix. And this is the mesoappendix right here that attaches the appendix to the cecal tip. Looking at a short axis view with and without compression, and you can just see that we do not have any compression of the appendix, but I think it would be quite obvious that a case like this you will not get any compression in. Short axis view of cases of acute appendicitis. Here's the inflamed appendix. You can see distension of the lumen, some pus that's located in here, but look at what, almost looks like a donut surrounding it. And this is just edema of the fat surrounding this short axis view. Here we can see a little bit of blood flow in the outer layer or the serosal layer of the case of acute appendicitis. Now, even if the appendix becomes gangrenous and avascular, you can still pick up hyperemia within the mesoappendix. So sometimes you won't always see increased blood flow within the appendix. It can become gangrenous and avascular, but you will pick up blood flow within the mesoappendix, and you can see that low velocity flow that we see within this case of hyperemia of the mesoappendix. What are some pitfalls that can lead to a diagnosis of false negative? Segmental appendicitis is one of them, having a patient with retrocecal appendix. If you have a gangrenous or a perforated appendix and you assume that it's normal, air within the appendix, you mistake it, and also a markedly enlarged appendix. So the first thing, looking at segmental appendicitis. We've already talked about this, but it's something very important. Make sure that you scan to the distal end of the appendix. Segmental appendicitis is when the proximal portion is normal, and make sure you do see that distal. So looking here, you can see the body of the appendix is normal. Here the fundus is just abnormal, so a small case of segmental appendicitis. Retrocecal appendix, as we already mentioned, it's difficult to visualize, as I talked about. Rolling the patient up into sort of a decubitus approach or rolling them up on their side and try and come in behind the cecum can be helpful in locating cases of retrocecal appendicitis. Here was a case that we had of a patient with retrocecal appendicitis. You can see that the appendix or the cecum is inflamed. Here is the appendix that is retrocecal, but very difficult to identify. Typically what we look for, once again, is that edematous fat that is behind the cecum. Now, looking at a gangrenous or perforated appendix, what will happen is you'll lose the echogenic submucosal ring, and what we're looking for is more of an inflammatory mass or abscess that we'll see within this. So in scanning this patient, when we put the transducer down, we found what I like to call a big Goomba, where you're like, what on earth is going on here? But you can see just all of this, inflammation that we can see within it, and scanning around, we were actually able to find what looked like a short axis view of a normal appendix. But here is the appendical lith, and this is the appendix that has perforated, and you can just see all of the edema that we see and just this big fluid collection, a big phlegma down there. So make sure that you don't call this normal appendix because you see what looks like it, but this is typically what a perforated appendix will look like. And you can see that there's increased blood flow